Well, I'm really happy to be able to talk to you today about frontal fibrosing alopecia. This is a condition that I see very, very commonly now, and very seldom does a clinic go by where I haven't seen one or more patients with frontal fibrosing alopecia. And it's a condition that I think we're learning more and more about now. We've come to understand in the last year that there's 4 genes that are very relevant. We're coming to understand what treatments are better than others with frontal fibrosing alopecia. And I'd like to share some of that with you today and, of course, answer any questions that you have. I don't have any conflicts of interest about anything I'm going to talk about today. What I would like to review with you is what is our current understanding of frontal fibrosing alopecia in the present day? What are the clinical features of this condition? And how best should we be treating it? This is a very typical feature, clinical picture of frontal fibrosing alopecia, and all lectures on frontal fibrosing alopecia start with a picture of the frontal forehead. But when you think about it, many patients first develop their frontal fibrosing alopecia with eyebrow loss. And it can be many years after their eyebrow loss that it's ultimately pieced together that the changes that the patient is developing in their hairline is frontal fibrosing alopecia. And so even though we're going to begin with a discussion of the hairline features of FFA, it's important to remember that many women start with eyebrow hair loss. But this is a picture of the frontal forehead. We can see that the frontal fibrosing alopecia affects the frontal hairline, and in other conditions like androgenetic alopecia, the frontal hairline is not affected in this same manner. There may be redness in the scalp, there may be scaling around the hairs as these hairline changes are occurring, but sometimes there's not. A patient may be completely asymptomatic. They may not even know that they have these hairline changes until something else is brought to their attention. Sometimes it's the hairline changes in the sideburns that prompts the patient to come to clinic, or of course more marked recession that causes them to seek medical attention, or their eyebrows, or they suddenly now start developing scalp symptoms like itching and burning that they never had before. But frontal fibrosing alopecia is a condition that affects the frontal hairline, but it also affects the sideburns and the back of the scalp. It affects the eyebrows, the eyelashes, the body hair, the pubic hair, the axillary hair, and the body hair. And we've come to realize as well that the facial skin is also affected in FFA. These are the so-called facial papules. And so this is a complex condition that affects multiple hair and non-hair containing areas. Most women with FFA are between 45 and 65 when they first present. Frontal fibrosing alopecia can affect men, but it's much less common. We don't know the true incidence rates of FFA. My feeling is that FFA affects anywhere from 1 in 5,000 to 1 in 10,000 women in the population. That, of course, depends on the country you're speaking about. But these would be my estimated prevalence rates for North America. But again, good studies haven't been done, but it would seem that classic frontal fibrosing alopecia would be somewhat less common than lichen planopilaris, another scarring alopecia that you might be familiar with. We don't really know the cause of FFA fully, but the last year has been a tremendously productive year for understanding some new insights into the cause of frontal fibrosing alopecia. It's thought to be an autoimmune disease, and it's thought to very closely resemble lichen planopilaris. And it's thought that frontal fibrosing alopecia, this scarring alopecia, frontal fibrosing alopecia, is a subtype of classic lichen planopilaris. When patients develop this scarring alopecia that affects the middle of the scalp and the crown, we refer to it as lichen planopilaris. When it affects the front of the scalp and the eyebrows and the body hair in this classic manner, we refer to it as a specific subtype of lichen planopilaris called frontal fibrosing alopecia. And so when I was thinking about how can we describe frontal fibrosing alopecia in one sentence, in one breath, I came up with this sentence, and that is that frontal fibrosing alopecia is an increasingly prevalent autoimmune disease associated with hormonal dysregulation, whereby individuals with an underlying genetic predisposition develop a scarring alopecia as well as skin changes due to some environmental insult. And so I think in the current day and age, that's probably our best definition that encompasses many of the aspects of FFA. Let's take a look at some of these points in turn, and we'll come to understand a bit more about frontal fibrosing alopecia. So FFA appears to be an increasingly prevalent autoimmune disease. Is that true? Well, I think it is true. Frontal fibrosing alopecia was first described in 1994 by Dr. Cossard in Australia. And the textbooks don't contain descriptions of frontal fibrosing alopecia like this in 1984, 74, 64, or 44. And so it appears that this was a condition that was introduced into the world in the manner we have come to understand it now in 1994, and then became increasingly recognized after that. You know, dermatologists are quite astute, and when you look at the medical literature in the 1800s, 1900s, we realize that dermatologists were reporting all types of observations of the skin, the mucous membranes of the nails, and there's no reason to believe that frontal fibrosing alopecia existed, and dermatologists simply never caught it. That just makes no sense. And so it appears that it truly is an increasingly prevalent autoimmune condition. And if you were in a dermatology clinic in the 1990s, a physician or dermatology trainee would say, "Never heard of this condition you're talking about." Whereas in the present day and age, a physician or a resident would say, "Sure, I've not only heard of it, I've seen many, many patients with frontal fibrosing alopecia." And when you look at Google Trends for FFA over the last 10 years, I punched the word FFA into Google, and this shows the trends for how many people are looking up frontal fibrosing alopecia compared to how many people are looking up telogen effluvium or hair shedding. And you can see that hair shedding has remained quite constant over time, whereas an increasing number of people are interested in frontal fibrosing alopecia, again paralleling the fact that it's increasing in prevalence. And so we need to understand more about it because our patients are becoming more and more aware of this condition. So it's an increasingly prevalent autoimmune disease, and there's some strict definitions about what truly constitutes an autoimmune disease, but one of the things we realize about an autoimmune disease is it frequently is associated with other autoimmune diseases. So is this true with frontal fibrosing alopecia? And the answer is yes, that many women with frontal fibrosing alopecia have other autoimmune diseases as well. About a third of patients with FFA have hypothyroidism. Lichen planus of the mucocutaneous skin is present in about 28% of patients, but psoriasis, vitiligo, lupus, Sjogren's, ulcerative colitis, these can occur in a small number of patients as well. And so we really need to take good histories of patients with FFA that present to clinic, and we need to be thinking about these other autoimmune diseases. Of course, many patients don't have these other autoimmune diseases, but we need to be taking good histories, asking about the mucous membranes, asking about the bowel, asking about fatigue, sore joints, skin rashes. These are very, very relevant. And we do think that frontal fibrosing alopecia is associated with other types of inflammation, including abnormalities in this PPAR gamma pathway, as well as abnormalities in what we call neurogenic inflammation. And neurogenic inflammation is a type of inflammation associated with inflammation produced by nerves. And this slide helps us to understand some of these aspects of neurogenic inflammation. And what neurogenic inflammation essentially is a type of inflammation that comes from nerves telling the skin to degranulate their mast cells. And in this particular diagram, what you can see is that in the presence of an environmental stressor, we've come to understand that our hypothalamic pituitary axis produces increased amounts of cortisol, and this increased cortisol can tell our dorsal root ganglion in our spinal column to send signals to the skin, and certain hormones like substance P can be expressed, which in turn cause mast cells to degranulate. And these mast cells in the skin have many chemicals inside of these little bags that the mast cells contain. And degranulation of these mast cells causes what we call neurogenic inflammation. And so this concept of neurogenic inflammation is probably very relevant to frontal fibrosing alopecia. And we'll go into it more at the discussion if you're interested. But one can't really understand fully frontal fibrosing alopecia without bringing into the discussion some of this neurogenic inflammation concept. And so it's thought that some patients with frontal fibrosing alopecia who experience this increased scalp sweating is mediated by neurogenic inflammation. And so there is a proportion of patients with FFA that are very troubled by increased scalp sweating along the frontal forehead. And it can be quite troublesome, quite disabling for many of these patients. But what's so remarkable is that this scalp sweating can be shut off with Botox injections or botulinum toxin injections. And so this is thought to be quite relevant in the mechanisms that are leading to frontal fibrosing alopecia. This is a diagram of a hair follicle. This is a patient with orange hair. So this structure shown here is a orange hair fiber going deep into the scalp. At the bottom of the scalp, we have the hair matrix and the dermal papilla. On the right side of the diagram, we have these little yellow balls, which are the stem cells, and we have this structure at the side, which is the sebaceous glands. And these stem cells reside in the middle of the hair follicle, and the stem cells are very, very important because it's the stem cells that give rise to a new hair during each hair cycle. And in 1990, Dr. Kotsarellis, who's now at Penn, discovered these stem cells as still a trainee. And these stem cells are very, very important because it's now understood that in frontal fibrosing alopecia and many of these scarring alopecias, that the inflammation that's present is at this region of the hair follicle where the stem cells live. And so in many of these scarring alopecias, it's thought that the immune system gets activated and this inflammation then attacks the hair follicle at this region where the stem cells are and this region where the sebaceous glands are. And so when you look at a biopsy of a patient with frontal fibrosing alopecia, you see inflammation, you see scarring. And where do you see it occurring? You see it in the middle of the scalp in this particular region, which is known as the infundibulum and the isthmus, and more in the isthmus. And it's thought that this site is very, very relevant to the ultimate destruction of the hair follicle and the destruction of the sebaceous glands that characterizes these particular diseases. And so this diagram on the left shows a cartoon of what we see in frontal fibrosing alopecia with this inflammation high up in the scalp, destroying the stem cells, destroying the sebaceous gland. And on the right, we see a cartoon or a schematic diagram of what we see in alopecia areata, which is a completely different hair loss condition. In alopecia areata, the inflammation is located at the bottom of the hair follicle, And in alopecia areata, the stem cells are not affected, they're not destroyed. And so if we can get rid of the inflammation in alopecia areata, we might be able to grow back the hair because the stem cells are still there. In frontal fibrosing alopecia, if we get rid of the inflammation, often what we can do is we can stop the disease. In some cases where the stem cells are not completely destroyed and we can get back new hairs, but often in these scarring alopecias, the best we can do is prevent it from getting worse. So in scarring alopecias, the inflammation is found in the upper part of the hair follicle, in this isthmus, and it's thought that this destroys the sebaceous glands and the stem cells. But the other thing that we see, in addition to the inflammation, is the scar tissue. And this blue here in this cartoon is showing scar tissue wrapping itself around the hair follicle along with the black dots, which is the inflammation. And so fibrosis or scar tissue along with inflammation is very much a part of what we see in frontal fibrosing alopecia, along with the disappearance of stem cells. And so when I'm looking at a biopsy report of classic frontal fibrosing alopecia, what the pathologist reports is I am seeing inflammation in the upper part of the hair follicle in the region of the isthmus. I am seeing perifollicular fibrosis around the hair follicle in this region as well, and I am seeing a disappearance of the sebaceous glands. This is very typical information that you will see in a report from patients with frontal fibrosing alopecia. And so this is a very typical histological specimen of a patient with lichen planopilaris, or what we would expect to see in a patient with frontal fibrosing alopecia. And what we can see here is that we have a piece of skin, and we have hair follicles in the skin, and you can see there's this increased intensity of blue dots hugging those hair follicles. That is lymphocytes, which are surrounding those hair follicles. Much of the other parts of this skin specimen are unaffected by these blue dots. That's because the immune system is specifically targeting the hair follicles. This is what we mean by primary scarring alopecia. And so when we look up close, we see something like this. This is a magnified view where we see a hair follicle in the middle of this diagram, and we see inflammation, or these tiny blue dots around the hair follicle, attacking the hair follicle in a very specific way. And this is what is sometimes referred to as lichenoid inflammation, and it's causing a specific destruction of these hair follicles. And so a pathologist, in looking at this particular slide, would comment on the inflammation around the hair follicle. There is destruction of some of the cells in the hair follicle outer root sheath, which is called a lichenoid change or apoptosis, cell death, and there's some increasing amount of fibrosis present as well. And so the patient's own immune system is attacking the hair in this particular condition. And so FFA is an increasingly prevalent condition. It's thought to be an autoimmune disease, and there's evidence for that. And it's associated with hormonal dysregulation. And there's some evidence to suggest and support that FFA is associated with hormonal dysregulation. It occurs in perimenopausal and postmenopausal women more commonly than young women, which suggests that some of the changes of the perimenopausal period may be relevant to this condition. Some women, but not all, have low serum androgens. Some women have early menopause, which is associated with declining estrogen. The ovary is responsible for the production of estrogen as well as testosterone, and so the more research is really needed to understand the relevance of this and the hormonal changes that are present, but these are likely very relevant to what's causing frontal fibrosing alopecia. Many of these women will give histories of having hysterectomies, but of course not all, and so there may be a slight difference in presentations among different subpopulations. Some women having hysterectomies, some women not, some women having early menopause, some women not. But many studies support that menopause is occurring slightly earlier in patients with FFA. That doesn't mean that all women with FFA have early menopause, not at all. But in general, when you take many hundreds of patients with FFA, you'll find that the age of menopause is slightly earlier than women with other types of hair loss conditions. Other hormones, in addition to estrogen and testosterone, may be abnormal in women with FFA, including thyroid hormones. And so about a third of women may have thyroid dysfunction in frontal fibrosing alopecia as well. And so this is important information because when you're evaluating a patient in your clinic with FFA and you're wondering about what blood tests to order, certainly you may consider ordering tests for thyroid function, as well as typical things like iron and vitamin D. But evaluation of things like estrogen status and androgen levels may be very relevant as well. In a very young patient with FFA who's in her 20s and 30s, it may be relevant as well to screen for early menopause in these patients as well. So it's an increasingly prevalent condition associated with autoimmunity, associated with hormonal dysregulation, and there may be a genetic predisposition. Now, many women with FFA don't have histories of other people in the family with FFA, but some do. But there's been some very fascinating research in the last year or so which has shown that there may be 4 genes or 4 genetic changes that predispose women to develop FFA. And if they have these particular genetic changes, they may be slightly more increased to develop FFA. These are the name of the 4 genes. 3 of these genes, or if present, increase the risk of FFA slightly. But HLA-B is a particular genetic change where if women have this, they may have a 4 to 5-fold increased risk of developing frontal fibrosing alopecia. And this is thought to be a relevant gene that may affect how the immune system functions and presents antigens. And so these particular 4 genes are increasingly being studied. There are no tests available yet where you can send a patient off to screen for these particular changes. Many patients may ask you that. They're interested to learn that these genetic changes have been identified, but we don't have a means yet of screening for patients for these genetic changes. But it's also important to keep in mind that frontal fibrosing alopecia is an uncommon condition. It occurs in about 1 in 5,000 to 1 in 10,000 women. And so if a patient has this particular genetic change, it may mean that her risk of developing frontal fibrosing alopecia is increased, let's say 1 or 2-fold. But if the disease is 1 in 5,000 to begin with, that means that her risk of developing FFA, if she has this particular genetic change, it could be 1 in 2,500. So her chances of developing frontal fibrosing alopecia, if she does have this particular genetic change, is still very low. And so we don't really know what to do with this information yet. It's very, very important because it helps us to understand that there are these fundamental genetic changes that increase the risk for FFA, but we don't know what to do with this information yet. If we're able to say to a patient that you have this genetic change, your risk of developing FFA is 1 in 2,500. There's a 99.995% chance that you'll never develop FFA in your life. Perhaps this patient should not make any particular changes in her life with this information. And so we have to be very, very careful with genetic tests, what this information allows us to do, and what it all means. And so we're still in the early stages of understanding this. But the main point that I would like to give to you is that we don't yet have these tests available. And once we do have these tests available, we still have to be careful about what to do with this information, because it may not have, it may not mean that this patient will develop FFA ever in her life. And so frontal fibrosing alopecia is autoimmune. It's associated with hormonal dysregulation. There's this genetic predisposition, and it's a type of scarring alopecia. So where does the hair loss occur? Well, it can occur on any hair-bearing site. The scalp can be involved, the eyebrows can be involved, the eyelashes, the frontal hairline, around the back of the hair, the body hair, axillary pubic hair. The eyebrows are often one of the first sites that become involved in frontal fibrosing alopecia. And one of the important messages that I'd like to deliver to you today is that any female patient in her 40s and 50s that presents to your clinic with eyebrow hair loss, please consider frontal fibrosing alopecia first. We're used to considering alopecia areata first, but the reality is that you will often diagnose frontal fibrosing alopecia at some of the earliest stages possible if you consider frontal fibrosing alopecia as top of your list in a 45, 55, or 65-year-old woman with bilateral eyebrow hair loss. You might say to yourself, you know, this patient is presenting to my clinic with eyebrow hair loss. I'm not sure if it's frontal fibrosing alopecia or alopecia areata. I think what I'm going to do is I'm going to perform corticosteroid injections into the eyebrow. If the eyebrows grow back a bit, it's proof that it's alopecia areata. If the eyebrows don't grow back, it's probably more suggestive of frontal fibrosing alopecia, because after all, it's a scarring alopecia, and I've learned that hair growth doesn't usually come back. The problem with thinking in that manner is that eyebrows can grow back with steroid injections in frontal fibrosing alopecia. So using steroid injections as a test is not a good way of differentiating frontal fibrosing alopecia from alopecia areata. What is a good way is a proper examination with dermoscopy. Many patients with frontal fibrosing alopecia will have redness in the eyebrow. They'll have eyebrows moving in all different directions. There'll be twisting and kinking of hairs, and they may show some of the earliest changes in the forehead hairline as well. Here's a patient with eyebrow hair loss in FFA. It's often a diffuse loss in the eyebrow with hairs moving in all different directions. It's usually not quite as well circumscribed as we see in alopecia areata. This patient has alopecia areata, and by circumscribed we mean we can draw a line around the hair loss. In frontal fibrosing alopecia, the hair loss tends to be much more diffuse, and so it's a reduced density, it's patchy, you can't draw a line around it, there's redness, occasionally scale, but not often, and the hairs are moving in different directions. We call it frontal fibrosing alopecia, but the hair loss moves around to the back of the scalp, especially in these margins behind the ears. It's a very common area to look for when you're examining the back of the scalp. But about a quarter of patients with FFA will have involvement of the occipital scalp, so it's important to look for. And this region behind the ear, as I mentioned, is very, very important. Some patients with FFA will mention to you that they occasionally get itchy behind the ear, and that's important because you may decide you want to perform steroid injections in that area. You may decide you want to have the patient using treatments in that area at home, whether it be topical cortisones or topical calcineurin inhibitors like tacrolimus or pimecrolimus. And in fact, when you're trying to figure out if a patient has involvement in the back of the scalp, it can be tricky. You may want to simply ask your patient, do you get itchy back there? And if the patient says yes, more times than not, you'll be right in assuming that the patient has involvement in that area. And so what are the skin changes that occur in FFA? We're learning now that not only is this a condition of the hair, it's a condition of the skin. And it's a condition of the immune system as well. And so we see that there can be thinning of the skin. Patients with FFA have more see-through skin where the veins become much more visible. And so when you look at the scalp of a patient with FFA, it's important to take photographs, and I would encourage you to take photographs. Many of you take photographs. It's important to take photographs because the skin changes that occur in FFA can easily be confused with the skin changes that occur with topical cortisones. And so when you see the scalp of a patient with FFA and you're seeing this see-through skin and you're seeing that these veins are much, much more visible, your tendency might be to say, you know what, I think this is occurring because we're using too much topical cortisone. That may be true, but the visible veins may be becoming from the atrophy from the disease itself. And so it's important to take pictures of the skin from the very first day you meet the patient so you can have some understanding of the skin changes that are present. Patients also develop facial papules, and these are yellowish goosebump appearing papules that can occur on the temples, on the forehead, on the chin. And these can be subtle in some cases that are just thought to be age-related changes. Some patients have said, you know, I went for years for various facials trying to get rid of these changes in my skin. But these are facial papules, and this was initially thought to be due to inflammation in the tiny hairs of the face, but we've come to understand that perhaps these are also due to changes occurring in the elastic fibers, and so there may be more to frontal fibrosing alopecia than just changes in hair follicles, that there may be changes in other aspects of the skin as well. And so this is an example of some patients whereby we see prominent facial veins. When you look at the scalp, a photograph can capture that the veins are much more visible, much more see-through, and this is important to follow as well. This is an example of the facial papules. This is the cheek area of a patient with this roughness in the skin. These are the facial papules of frontal fibrosing alopecia, and can be challenging to treat, and as I will explain in several slides ahead, the most effective treatment for facial papules as we understand it now is retinoids, or the use of isotretinoin. So FFA is this increasingly prevalent autoimmune condition associated with hormonal dysregulation. There's this underlying genetic predisposition with these 4 genes. There's these skin changes, and then there's this environmental insult. Because frontal fibrosing alopecia was first recognized in 1994 and is increasing in prevalence, the thought is that there's something in the environment that wasn't present in the 1920s, 30s, 40s, and 50s that is predisposing women to develop this condition. And really the race is on now to understand what could be the culprit. And now that we understand there's this genetic predisposition, I think that helps a lot because we can understand more about what these genes are and gain some insight into some potential triggers. But for the most part, we don't really understand yet what is the environmental insult that's responsible for FFA, if there is an environmental insult. Certainly sunscreens and facial moisturizers have been suggested by some reasonably good research as potential culprits. It is not clear why sunscreens are implicated. It is thought that perhaps there are some small particles, nanoparticles, perhaps containing titanium dioxide, perhaps containing other ingredients that are so small they're trapped in the hair follicles. They incite this autoimmune reaction, but it's really not clear. It's been shown in some reasonably good studies, both in men and women, by Dr. Messenger's group in the UK, that women with FFA are much more likely to be using sunscreens than women without FFA, and the same is true with facial moisturizers. And these studies have also been done in men with FFA, which is a rare condition, and the same findings held true that men with FFA were more likely to be using these moisturizers as well. And so there may be ingredients in these particles that, in these substances that somehow incite an autoimmune reaction in hair follicles. More studies are clearly needed. But there is one very interesting study showing that in a patient with FFA who stopped using sunscreens, that there was some improvement in the FFA. And so that's very interesting. And so the question then arises, should we now be universally recommending to patients with FFA to avoid sunscreens and avoid moisturizers? We don't really know that yet, but it certainly is very interesting work. And so more studies are really needed, but it's thought that perhaps the use of sunscreens blocks ultraviolet radiation, which is great. That's why we use sunscreens. But we now know that ultraviolet radiation, or we've known for a long time that ultraviolet radiation is immunosuppressive, so it stops inflammation. And so perhaps by blocking it, we incite inflammation. And so we have more research that's needed, but it's an interesting area, fascinating area of study in this sunscreen and moisturizer area. And of course, the race is on to find the environmental trigger, and we still don't know, but there's some questionnaire-based studies that are looking at what do patients with FFA do that patients without FFA don't do. And one study showed that the use of the intake of buckwheat and millet groats was increased in women with FFA compared to women who didn't have FFA. So this was one of the studies with Dr. Messenger's group in the UK, which showed that when you compare women with FFA to women without FFA, 48% of women with FFA were using sunscreens quite commonly compared to 24% of women without FFA. And this study initially got quite a bit of criticism. All questionnaire-based studies have their flaws, their limitations in study designs. But it was a fascinating study because there was no understanding at the time of any possible environmental trigger in FFA. And again, as I mentioned, Dr. Messenger's group went on to find the same observation in men with FFA. And so we are now at a point where research is looking at what are some of the factors that might predict women with FFA having more severe disease, having a more resistant form of FFA. And some of the factors that are associated with more severe disease include the presence of facial papules, the presence of eyelash loss, the presence of body hair loss. And a very recent study looked at 5 particular factors which were associated with having more severe disease. And that is women who come into clinic slightly older, having an older age when their FFA started, having had their FFA for a greater number of years, having a higher body mass index, are more likely to be in the clinic with more severe FFA. And so it's an interesting period where we're starting to understand some of the factors that are predictive of more resistant and more severe forms of the disease. And this will ultimately help us to counsel patients on therapies and how aggressive in treatments they might want to consider if they are going to stop this condition. So how do we diagnose frontal fibrosing alopecia? Well, the presence of hair loss along the frontal hairline with trichoscopic or dermatoscopic findings showing inflammation around these hairs, with loss of the vellus hairs and recession of the forehead hairline from what it used to be is certainly an indication of frontal fibrosing alopecia. But it is possible to say, at least with some likelihood, that a 55-year-old woman with thinning of the eyebrows without any hairline changes also has frontal fibrosing alopecia. But that's a little tougher diagnosis to be 100% confident. And a biopsy may be needed if that is required, if one needs to solidify the diagnosis fully. But the diagnosis of frontal fibrosing alopecia comes from understanding this change in the hairline along with some degree of associated inflammation. There may be hair loss around the back of the scalp, as we mentioned. There may be redness in the frontal hairline. There may not be redness in the frontal hairline. There may be scale in the frontal hairline. There may not be scale. What we often see as the hairline moves back is there are some hairs that are not as affected. And what that means is that some hairs are left behind as the hairline continues to move back. And you can see these hairs in the front of the scalp, and these are what are referred to as lonely hairs. That's just a term that Dr. Tosti had put forth a number of years ago. And lonely hairs are hairs that are sitting out in the frontal forehead skin that have not yet been removed by the disease. Lonely hairs are by no means pathognomonic of frontal fibrosing alopecia, but are often seen and can be suggestive of the disease. Now, some patients, when you look at the scalp, even without trichoscopy, have redness around the hairs. Some have scale around the hairs. That's important. There may be this loss of the sideburns, which is very much in keeping with frontal fibrosing alopecia. And the sideburn loss in frontal fibrosing alopecia is generally symmetrical. And that's one of the differentiating features from alopecia areata. Patients with alopecia areata may have a patchy, random area of hair loss. With frontal fibrosing alopecia occurring in men or women, it's usually quite symmetrical. The eyebrows may be lost. Often they're not completely lost initially. They're thinned in a patchy manner, and there may be redness in the eyebrow that the patient has as well, sometimes some itching. And when you look up close, there's hairs that are moving in all different directions on account of the hair loss. As I mentioned earlier, the hair loss in the eyebrow in frontal fibrosing alopecia is different than in alopecia areata, where in alopecia areata it's much more well circumscribed. You can draw a line around the area of hair loss in alopecia areata. There may be prominent loss of the eyelashes. In frontal fibrosing alopecia, the most common way which we see eyebrow density affected is a symmetrical reduction in density associated with some redness, but not a well-circumscribed patch, at least not initially. There are a number of mimickers of frontal fibrosing alopecia, so it's important to be aware of these. Sometimes a patient has both conditions, and so being able to accurately diagnose what's going on in the scalp is important. Hairline changes can occur in androgenetic alopecia, which is shown here on the left. Women with androgenetic alopecia often keep the very frontal hairline. It may be thinned slightly, but the actual architecture is still preserved. The typical hair loss in androgenetic alopecia occurs behind the frontal hairline. They have thinning occurring behind the frontal hairline, but the actual architecture is somewhat similar in androgenetic alopecia, and so it's classically said that women with androgenetic alopecia don't lose the frontal hairline. In frontal fibrosing alopecia, in contrast, the actual frontal hairline is changed and it moves back over time. Traction alopecia is another condition which affects the frontal hairline. Traction alopecia can occur from many causes, including the use of braids, weaves, cornrows, tight ponytails, anything that puts increased forces on the hairs, causing them to be lost. This is a patient with traction alopecia. She has a very classic fringe sign where there's some hairs at the front of the scalp margin that haven't been pulled quite as effectively or efficiently by the braids that were used in this area. And so that's very typical traction alopecia. It is possible in frontal fibrosing alopecia to see a fringe sign like this, but often in frontal fibrosing alopecia, such a fringe sign would be more uncommon. Alopecia areata can look somewhat similar sometimes, especially as it's more advanced. In frontal fibrosing alopecia, we often look for that atrophy. We look for the redness around the hairs. We look for scale around the hairs. Those are typically absent in a patient with alopecia areata. Trichoscopy, or the use of these handheld dermatoscopes, is very helpful in all of hair loss, but it's also very helpful in the diagnosis of scarring alopecia. And Some of you had spoken to me about different dermatoscopes that I use. I've used many different dermatoscopes in the past, and I think all can be very helpful. Some I prefer because they can integrate with my iPhone a little more readily. But I think the most important thing is just starting with a dermatoscope and over time just acquiring some skills. They can be very helpful for picking up some subtle signs that you might otherwise miss by just examining the scalp with your eyes. The dermatoscopic features of frontal fibrosing alopecia are the presence of single hairs in the frontal hairline, so the groups of 2 and 3 hairs are not present. But one of the most important features that we can see in frontal fibrosing alopecia is that these tiny vellus hairs, or what some people refer to as baby hairs, are destroyed by the frontal fibrosing alopecia. We may see redness around some of the hairs, but not always. And we may see scale around the hairs, but not always. And so these are important features to try to identify with the dermatoscope because these have meaning. If you see redness and scale around the hairs with your dermatoscope, it means that there's inflammation underneath the scalp in that area. And if you don't modify your current treatment plan, or you don't start something potentially effective, the patient is quite likely to lose those hairs over time. So here's a very typical dermatoscopic image of frontal fibrosing alopecia. We see single hairs in this particular slide. Hairs are not coming out of the pores in groups of 2 and 3. They're just coming out of the pores in single hairs. There's a little bit of redness in some areas. There's a little bit of scale around some of these hairs. There's a whitish scale wrapping itself around some of these particular hairs. Some of the scale in FFA can be quite prominent. Some of the scale can be quite difficult to see, and it may not be present at all. This is a patient with quite prominent scale around the hairs. This is a very typical feature. This is a very typical dermatoscopic image of frontal fibrosing alopecia. The pores or the follicular openings are not present because this is a scarring alopecia. And this dermatoscopic image mimics what lichen planopilaris would look like. And as I mentioned earlier, lichen planopilaris and frontal fibrosing alopecia are thought to be very, very closely related. But this is a dermatoscopic image of FFA, and it would look identical to lichen planopilaris for the most part. Sometimes we see redness around the hairs. It can be subtle. Sometimes we see twisting of hairs. The hairs are twisting as they're pushing their way through scar tissue. The reason identifying this redness around hairs, which we call perifollicular erythema, and the reason identifying the scale around hairs called perifollicular scale is so important is that these are associated with disease activity. And so if your patient has redness and has scale, and you administer a treatment, and 2 or 3 months later you find that redness and scale are diminishing, it means that you're probably achieving some improvement in the clinical activity that that patient has. It doesn't mean that you've completely shut off their disease, because some patients reduce their scale and they reduce their redness, but their hairline still moves back. And so you still have to follow these patients carefully, but it's certainly a very, very good sign. The other point that I'd like to make before we leave this concept of trichoscopy is that when you look at the scalp, you're more likely to see redness and scale in the frontal area than you are at the side. And so if you're examining the scalp and you see at the side that there doesn't seem to be much redness, there doesn't seem to be much scale, don't necessarily use that as a sign that there's not much inflammation there. We don't usually see much redness and scale at the side. Here's a dermatoscopic image of this patient's forehead. There's some whitish scale around some of these hairs. If we look at a dermatoscopic image of the side of the scalp in this same patient, we don't see much scale around these hairs. And so that's important to be aware of, that these classic dermatoscopic findings in FFA, the scale, the redness, they're found here. We don't see them here classically, so don't use those as your criteria when you're evaluating FFA. Trichoscopy is helpful in very tough cases. I can't perform a hair clinic without my dermatoscope. It's that important. But I think that a trichoscope or a dermatoscope is really particularly helpful in tough cases. And why are we seeing more tough cases? Because people are aware of frontal fibrosing alopecia, as we mentioned before. Patients are coming into clinic very, very often, and their question to you is, do you think these hairline changes are frontal fibrosing alopecia? Often they're not. But it's important to have the skills and the tools to be able to confidently say to the patient, you don't have frontal fibrosing alopecia. You may feel you have frontal fibrosing alopecia, but you don't have frontal fibrosing alopecia. And so if we see that the patient's hairline has changed, and we see that there's a lot of baby hairs in the hairline, and there doesn't seem to be much atrophy, the veins really aren't that visible, we see hairs in the frontal hairline, we see some 2 hairs and 3 hairs. We don't really see any perifollicular erythema and scale. The patient reports no eyebrow loss. There's no eyelash loss and body hair loss. More likely than not, this patient has androgenetic alopecia or female pattern hair loss or some other diagnosis besides frontal fibrosing alopecia. And so a dermatoscope can equip you with some tools to be able to confidently say to this patient, you do not have frontal fibrosing alopecia. And of course, a biopsy can be done if there is any still some controversy whether the patient has FFA or not. But a dermatoscope and a dermatoscopic exam can really help you and the patient confidently rule out FFA in many cases. This is a dermatoscopic image from a patient who comes in and says, I think I have FFA. I've got all the signs. I've got the hairline changes associated with FFA. My eyebrows are changing. I'm concerned I have FFA. I have much less body hair than I used to have, much less underarm hair. My facial texture is different. When you look up close on the scalp in this particular patient, what you see in the frontal hairline is there's tons and tons of baby hair. You don't really appreciate that there's any redness. There's no scale around the hairs. And so this particular patient has androgenetic alopecia. I didn't think there was a particular need in this case to do a biopsy. And if the patient is satisfied with that explanation, great. If not, you may want to do a biopsy. But compared to this particular photograph where we see a patient with some redness in the scalp, these little tiny baby hairs are disappearing. We don't really see many baby hairs. There's an injured hair in the middle of the scalp here, which is kind of twisting and kinking on its own. It's true we don't see a lot of scale or redness in this particular picture, but this is a picture of a disease process which is destroying the baby hairs or the vellus hairs. And so if you're comfortable with seeing enough patients with FFA, you can say this is a scarring alopecia. If not, you may want to biopsy it. Where do you biopsy it? You biopsy it from an area which contains hair, but you biopsy it from an area that shows some of these changes, whether it's redness around hair or scale around hair, or a hair that's twisting or a hair that looks abnormal. If you can ideally do it a little bit back from the frontal hairline so they don't see the scar, that's better, but sometimes you can't. Here's another patient with hairline changes where all that we see is these single hairs. They're lining up in this frontal scalp and they're all the same caliber, they're all the same thickness. We don't see much redness around the hair, we don't see much scale, but we don't see these vellus hairs. This is frontal fibrosing alopecia. Can androgenetic alopecia ever fool you, that you lose advanced cases of androgenetic alopecia where you lose these vellus hairs and the patient has androgenetic alopecia? Yes. And so each patient case is taken on a case-by-case basis. But frontal fibrosing alopecia is an inflammatory, destructive process which causes a change in the hairline associated with the destruction of the vellus hairs. So what tests are needed? Well, do you need a biopsy, first of all? There was once a time that one would say that anytime you suspect a scarring alopecia, you should do a biopsy. This is still a reasonable rule to have, and so there's nothing wrong with having that as your rule. It will help you in many cases. But I can confidently say that one of the wonderful things about scalp dermoscopy is that when you do enough dermoscopy and you see enough dermatoscopic images, and you understand the patient's history, the history of their eyebrow loss, eyelash loss, body hair loss, changes in their scalp, where their hairline used to be, what's happening, the use of a dermatoscope can greatly reduce your need for a scalp biopsy, not only in frontal fibrosing alopecia, but in lichen planopilaris, folliculitis decalvans, dissecting cellulitis, many of the scarring alopecias. There's nothing wrong with having as a rule that I do a scalp biopsy in every FFA or any scarring alopecia patient I suspect. That's okay. But do remember that the wonderful thing about dermoscopy, or trichoscopy, is it reduces our need for scalp biopsy in some cases. What about blood tests? Well, I think everyone with hair loss needs CBC, TSH, ferritin, and vitamin D. TSH, ferritin, CBC, and vitamin D. These are the 4 essential tests for anyone with hair loss. But I really do think that for frontal fibrosing alopecia, we need some other tests as well. Frontal fibrosing alopecia is recognized to be a condition associated with hormonal dysregulation, and so we should be testing for hormones. I do believe that testosterone levels, free and total testosterone levels, are very appropriate for many patients. Testosterone deficiency is a real thing in FFA. How best to deal with this, we don't yet know. But if a patient has testosterone deficiency and presents with low libido, fatigue, and you remember in the last lecture that finasteride is one of the top treatments for frontal fibrosing alopecia, you might not want to use it in a patient with androgen deficiency. So I think androgens are important to screen for. I think estrogen is important to screen for. You may consider other androgens as well. I think in a premenopausal patient, it's very relevant to screen for the menopausal status. This is still controversial, but I do think that a 28-year-old patient who presents with frontal fibrosing alopecia needs to be worked up for the possibility of early menopause. Now, many of these patients won't have early menopause, but I think we at least need to consider that this is a condition associated with hormonal dysregulation. This may be a condition associated with abnormalities and pathology in the ovary, which is leading to a reduction in testosterone and a reduction in estrogen. And if you can identify early menopause in a very young woman with FFA who has not yet had her family, you can dramatically change that patient's life if she wishes to have children. And so I do think that thinking about the menopausal status is very important. Even if the patient does not wish to have children or doesn't wish to have additional children, by identifying early menopause in that patient, you can protect that patient's health from a cardiovascular status, from the emotional changes that may be associated with hormonal fluctuations, bone mass changes. And so there's many things that can be altered in that patient's health by identifying early menopause or abnormalities in hormonal status. And of course, an endocrinologist or gynecologist may assist you with this, but you can set things rolling, because a gynecologist or endocrinologist may not be familiar with the hormonal changes that can occur with FFA, but you can educate them, and you may change the patient's life by doing so. So what are the treatments for frontal fibrosing alopecia? Well, I'd like to review this with you in a manner that groups them into first-line treatments, things that we should consider first, second-line treatments, things that are in our toolbox that we consider second, and then third line. The third line options are things that we use, but we need to give careful thought to using them because they're third line. The most effective treatments for frontal fibrosing alopecia in the present day are retinoids like isotretinoin, acitretin, finasteride, dutasteride, steroid injections, and calcineurin inhibitors, things like pimecrolimus and tacrolimus, and topical steroids as well. These are the most effective treatments that we know from an evidence-based point of view, based on studies in the medical literature that I can go to a journal, pull it out, and say, this seems to help X percentage of patients. Finasteride and retinoids like isotretinoin are at the top of the list, and that's very, very important to remember. And even though we think of FFA as being very similar to lichen planopilaris, and the treatments are somewhat similar, the treatments at the top of the list for FFA are different than the treatments that are at the top of the list for lichen planopilaris. For lichen planopilaris, the treatments that are at the top of the list are hydroxychloroquine, doxycycline, steroid injections. For frontal fibrosing alopecia, isotretinoin and the 5-alpha reductase inhibitors like finasteride and dutasteride are at the top of the list. So these are similar conditions, but the treatments are slightly different. The second-line agents for frontal fibrosing alopecia includes hydroxychloroquine, tetracyclines like doxycycline, minocycline, topical steroids, and minoxidil. So certainly these can be very helpful, and many patients in my practice are on hydroxychloroquine for their FFA. They're on doxycycline for FFA. We're using a topical steroid. We're trying to stimulate hair growth with minoxidil. Absolutely. So second line doesn't mean that they're not used. It just means we must really consider carefully that we know that 5-alpha reductase inhibitors and retinoids are the most effective treatments. The third line agents are things like methotrexate and hair transplantation. And depending on our time, we'll discuss whether hair transplantation is a good option or not. I really think that hair transplantation needs very, very careful consideration before you attempt it in frontal fibrosing alopecia. It can work wonderfully in some patients. It can be an absolute disaster in some patients as well. A patient with frontal fibrosing alopecia who is more likely to be a good candidate for hair transplantation is a patient whose disease is stopped. There's no evidence of the disease progressing over the last 2 years. So that means a picture taken 2 years ago and a picture taken today shows no changes. The patient has no symptoms. The patient's on no medications. The patient's disease is truly burnt out. These are patients that are the most likely to do well with hair transplantation. A patient who says, you know what, I'm a little different. My hairline's a little different than last year. Not too much, but it's a little different. I still use topical steroids because I get itchy a little bit, and I'm still on hydroxychloroquine. This is a patient that you want to think twice about performing hair restoration with, in my opinion. Hair restoration can be much more successful in other scarring alopecias, like lichen planopilaris, if the candidate is correct. It is a very challenging condition in frontal fibrosing alopecia, and I think the patient needs to know that moving in. Are there successes with FFA and hair transplantation? Absolutely. But there are many cases that don't respond, and there are many cases whose disease worsens. And so that's why it's a third-line option. So let's talk about finasteride briefly. Let's talk about isotretinoin, because I think it's important to know the evidence for these, because these are first-line agents, and these are the most effective treatments. And so Sergio Vano-Galvan from Spain has performed some really wonderful studies, and this is a great study by his group. It's one of the larger retrospective studies. There's been some pretty large FFA studies that are coming out now. But this study looked at the use of finasteride and dutasteride in patients with FFA, and what this particular study showed was that finasteride actually improved patients. It improved their hair density. They grew more hair in 47%. It stabilized the disease in 53%. Dutasteride had a similar benefit with 44% improving and 56% stabilizing. And so what this particular data from Dr. Van O'Galvan's group suggested is that most patients with FFA have some benefit. Other studies haven't suggested that it's everybody, but this was a very important first step with a large number of patients. There have been other studies before Dr. Van O'Galvan's studies looking at finasteride, but this was one of the larger studies at that time in 2014 showing us that many patients do very well with these medications, and so they shouldn't be ignored. This was a study from 2017 looking at the use of dutasteride with a topical steroid. In this particular study, no patient actually improved their hair density, but about a third of patients were able to stabilize their disease. And another patient study from 2009 with just 13 patients showed that 15% improved and 46% stabilized. Again, showing us that these are helpful medications, and not only can we expect some patients to have their disease stopped by the use of these 5-alpha reductase inhibitors, but some patients may actually achieve a benefit, and there's no doubt about it that some patients are quite surprised to see an improvement in their hair growth. Some slightly smaller studies back in 2005 showed some similar benefits with disease stabilization in some patients, but no growth. This was a patient that we reported in 2015 showing that finasteride not only improved density, but finasteride reduced atrophy. The visibility of the veins was much reduced in these patients, suggesting that finasteride might not only have an effect on the disease in terms of hair regrowth, but on the skin as well. Steroid injections appear to be quite helpful in frontal fibrosing alopecia. One of the things that we give careful thought to is the atrophy that steroid injections can sometimes cause. And so it's important to take a picture, as I mentioned, and follow whether the veins are becoming more visible. And if they are, deciding, is it because of the disease worsening or is it because of my steroid injections? But steroid injections are performed into the scalp at anywhere from 2.5 milligrams per mil of triamcinolone acetonide upwards to 5 or 10 milligrams per mil, depending on your practice and your background and your comfort. My personal preference is to use 2.5 milligrams per mil as a starting dose. This dose reduces the chance of atrophy, can still be very helpful in some patients, and moving upwards if needed. That same study by Dr. Van O'Galvan, as I mentioned regarding the use of finasteride, also looked at the benefit of injections. And what that study showed is that there was some improvement that was thought to be attributed to steroid injections, where 44% of patients improved, and some patients stabilized their disease. There have been other studies as well by Dr. Bunka and colleagues. This was Dr. Shapiro's group from NYU looking at the benefit of steroid injections. This was a study of 57 patients, and what the conclusion in that study was is that all the patients had some kind of benefit from steroid injections. And so how do we group all this information together? The information is that steroid injections are a reasonable approach to be considering in your patients. And given their safety profile, it's reasonable to put them in a first-line group. So finasteride, dutasteride, retinoids, steroid injections, and tacrolimus, pimecrolimus, topical steroids. These are all our first-line treatments for FFA. This was a study about almost 10 years ago now that I conducted with Vera Price at UCSF, looking at the benefits of steroid injections into the eyebrow. This was a study which showed that steroid injections can benefit patients with frontal fibrosing alopecia with eyebrow loss. And in fact, some of these patients can actually get some eyebrow growth back. It's not in every patient, but the important message of this particular paper is that steroid injections into the eyebrow is a reasonable thing to do with some patients with FFA. And second, if you do a steroid injection, the regrowth should happen in a couple of months. And so if you do steroid injections and you don't see any change in 3 months, there's no need to do it again because it's probably not going to promote growth. What's a little more difficult is deciding whether the steroid injections might help this patient keep their eyebrows. That hasn't been carefully studied as well because studies are generally not 2 and 3 and 4 and 5 years in duration. But at least the possibility exists that treatments like steroid injections, topical steroids, topical calcineurin inhibitors, as well as other treatments might help prevent loss of the eyebrows. So what about isotretinoin? I think it's important to know about the studies of finasteride and dutasteride, but it's important to know about the studies of isotretinoin. This is a study by Dr. Rakowska, very nice study. And in her study of 29 patients, she showed that 76% of patients on isotretinoin stabilized. And in that same study, which included 14 postmenopausal patients, she found that finasteride didn't do quite as well, that about 43% of patients stabilized. And so her point is that maybe these retinoids deserve a lot more attention in frontal fibrosing alopecia, and maybe these retinoids are quite helpful as well. And so this is a very nice study, in my opinion, because it allows us to really keep finasteride and isotretinoin at the top of the list for now as effective treatments as systemic agents for frontal fibrosing alopecia. And so when I see a patient with frontal fibrosing alopecia, you have to review the entire medical history. The use of retinoids, the use of 5-alpha reductase inhibitors is not appropriate for everyone. A patient with a history of breast cancer may not be appropriate for a 5-alpha reductase inhibitor. A patient with mood issues, underlying severe depression, may not be appropriate for finasteride or isotretinoin. Isotretinoin is, and all the 5-alpha reductase inhibitors, of course, contraindicated in women of childbearing age, and so they're much more frequently used in postmenopausal women. Women with high cholesterol and issues with hypercholesterolemia may find that the use of isotretinoin is more challenging, given that it may predispose to increasing lipids. So the second-line agents are things like tetracycline, doxycycline, hydroxychloroquine, topical steroids, and minoxidil. Now, as we're trying to filter out these into first-line, second-line treatments, it's important to know that we often use topical steroids as first-line agents. That's true. The medical evidence would suggest topical calcineurin inhibitors like pimecrolimus, tacrolimus are probably more effective than topical steroids. And so it's important to somehow differentiate these by thinking in terms of first-line and second-line treatments. But hydroxychloroquine can help FFA. Doxycycline can help FFA. It just appears in the literature it's a little bit less effective than finasteride or isotretinoin. And so Dr. Van O'Gelvan studied 54 patients using hydroxychloroquine, and that particular study showed that 15% improved, 59% stabilized on hydroxychloroquine, and so about 75% of patients overall had some kind of benefit. The study by Strazula and colleagues looking at the use of hydroxychloroquine compared to doxycycline showed that 70% had some kind of benefit, and that hydroxychloroquine in that study was just as effective as doxycycline. And so as second-line agents, these are both reasonable options. There's no reason to believe that hydroxychloroquine is better than doxycycline, but there is reason to believe that finasteride and dutasteride and isotretinoin are slightly better than hydroxychloroquine or doxycycline in the present day based on all the studies that we have so far. What about the eyebrow-specific treatments? Well, we have corticosteroids, topical steroids, steroid injections. We have minoxidil, we have bimatoprost, which you're familiar with as Latisse, and we have a number of eyelash serums and enhancers that patients can buy over the counter and probably do something. And when we think about the eyebrow loss and FFA, I think it's important to do two things. It's important to suppress inflammation, and it's important to stimulate growth. And I particularly like to use a topical calcineurin inhibitor like pimecrolimus cream, occasional use of a topical steroid, maybe once a week or twice a week, and then encourage growth with minoxidil. The facial papules that I mentioned are found on the face and the temples. The most effective treatment in the present day appears to be isotretinoin, but really more studies are needed with these particular facial papules. And so how do we know if we're treating the condition properly? Patients often ask, I'm going to start these treatments, how do you know if they're working? Well, the way we really know it's working is with a photograph. And we're going to review a number of ways we know it's working, but I can't emphasize that enough. The best way to evaluate scarring alopecias is with a photograph, and whether you take that or your patients take the photographs is left up to you and your patient, but photographs are extremely important. But the first thing we look at is scale and redness around the hairs, and so if we start a treatment and the patient comes back 3 or 4 months later and they used to have redness and scale and now they don't have redness and scale, that's great. That means that there's probably a decrease in inflammation. It doesn't mean that the disease is completely shut down, because sometimes we reduce the scaling and redness, but the hairline still moves back. So we have to have a respect for what this information means. But the most important thing is a picture. And if you take a picture of a patient's hairline, their sideburns, the middle of their scalp, their eyebrows, and they look the same 1 year later, it means probably that the disease is stopping or slowing down. If you take another picture 2 years later and you compare the picture from 2 years apart and it looks identical, it probably means the disease has stopped. But again, frontal fibrosing alopecia can be quite slow, and so if you take a picture and you take a picture 4 months later and it looks the same, it doesn't necessarily mean anything, because the patient's FFA may be slow and in the next 4 months they may lose a little bit of hair. And so we have to remember that a photograph taken 1 year apart that looks the same might mean the disease is quiet. A photograph taken 2 years apart is even more reassuring that the disease is quiet. But a photograph taken 1 month apart that looks the same doesn't have any meaning at all. And so a photograph is extremely helpful. And in a busy practice, I completely respect it's difficult to take photos, store photos, have all the compliance in terms of how we store photos privately. This is a very challenging issue for clinics. And you may encourage your patients to take photos as well. Patients want to join you in helping them win the battle and beating this FFA. And patients are very willing to take photographs. They just need to know how to take them. And so it's a very important point, and that is the role of photographs. And certainly we take them in the clinic as well, but I do encourage my patients to take them as well. So in that, we'll conclude. Frontal fibrosing alopecia is increasingly prevalent. This is a condition for which the etiology is starting to unfold. We're beginning to understand that this condition may have some genetic predisposition, with this understanding that there are 4 genes that seem to be very relevant in FFA. There's no doubt about it that treatments like finasteride and isotretinoin and steroid injections are at the top of the list for treatments that are likely to be the most effective. That doesn't mean in your patients that these are the treatments that you will start with, because that's based on their history. But it's important to think about our treatments in first line, second line, and third line options. And again, hair transplantation is an option which is lower on the list and is something that must be given very, very careful consideration. And photographs are extremely important in evaluating FFA. These are not necessarily photographs up close with a trichoscope or a dermatoscope, although those are helpful, of course. This is a photograph taken from quite a distance, looking at the hair density. And if that hair density stays the same month after month after month, year after year, it's a pretty good indication that the disease is being stopped by your treatments. With that, I will conclude. I want to thank you again for your attention, and I'm really happy to answer any of your questions. Thanks very much.